This is Sg2 Perspectives, a conversation with industry experts and Sg2 thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
We're really all in awe of the creativity and dedication that a lot of our members are showing, both from the strategy team side, from the healthcare provider side, of course, in terms of being able to continue to deliver care to patients safely. Really just amazed by the interesting ideas and creativity that are coming out of our members right now.
Thanks for tuning in to Sg2 Perspectives. I'm your host, Trevor Durin, and today we have a lot of guests. Three of our service line teams are joining me to talk about some of the similarities and differences in how non-COVID patients still need access to hospitals and physicians during this pandemic. And specifically for this episode, we're going to talk about obstetrics, cancer, and neuro. This isn't the part of healthcare that's making headlines today, and nor is it the procedure-based care that health system planning teams are working so hard to model and forecast how they can try to have the revenue bounce back. But a lot of this care is unavoidable. A lot of these patients already were getting services before COVID patients started showing up. And that's why we grouped these three service lines together. So we have a lot of guests. I'll introduce them as we get into the question. So let's jump right in. What are some of the services that just didn't stop as health systems shifted to treating and preparing for COVID patients? Now, Kiran and Cory are our cancer team. So Cory, especially given your experience running a service line at a health system level, I want to start with you. Why don't you guys go first?
Thank you, Trevor. Appreciate it. I'm going to ask Kiran to go ahead and speak to some of the things that we're seeing within the oncology, specifically amongst the various types of treatments that are being impacted or potentially have the impact. She's going to speak a little bit about visits and infusion, then I'm going to take radiation and surgery. Kiran.
So services that haven't stopped, a lot is still happening despite COVID-19 in the cancer service line. I think the major change here has been in-person visits that can be avoided are starting to be shifted to telehealth where possible. So things like follow-up, survivorship visits, visits for side effect management for things like chemo. But a lot's still happening in cancer. We're going to break it out by the classic treatment types here. And just starting with infusion, the big changes there for programs, I think, have been really the adjustment to treatment schedules to reduce patient visits, getting these immune-compromised patients to stay home as much as possible. And then also changes to visit schedules and protocols to allow better social distancing within the clinic when patients do have to come in for infusion. But there's really no direct evidence right now to support changing or withholding chemo or immunotherapy in patients with cancer. It's just not recommended by ASCO and a lot of the other professional groups out there right now. Delaying things like stem cell transplants could be reasonable, depending on whether or not the cancer is well controlled with other treatments. Things like immune checkpoint inhibitors, you could possibly consider a less frequent dosing schedule. But, as you can tell from what I'm saying here, this is really a patient by patient, case by case basis. So the real story here is that a lot of things are still happening for us here.
Yeah, and I think the important point here, Kiran, is as we've seen from a broad service line on cancer, that the coordination of care is extremely important. As we look at the other two modalities, specifically with radiation and surgery, there's a lot of case-by-case decisions that are being made. We know that a lot of programs, and Kiran cited the fact that our societies like American Cancer Society and cancer surgeries are basically putting out guidelines to really kind of help guide some of these discussions. We know a lot of service lines and programs are really developing also internal triage protocols to help kind of guide the decisions. And when we look at radiation specifically, some of the things that are occurring there is, again, case by case, but some of the treatments are being scheduled later or reduced, with hyperfractionation being kind of a treatment that's not necessarily new, but it's being more utilized to help maybe treat patients on a shorter course of treatment around the plans. So delayed treatments are there. Schedule shifts of treatments are happening to some degree, but again, case by case. And then as we look into the surgeries aspects of care, again, this is kind of a case by case. A lot of decisions are being discussed about how the treatments need to be done based on advancements of the disease. We know that recommendations for breast cancer and some colorectal surgeries can be pushed up to 3 months. But again, these are all based on the teams coming together and kind of evaluating those. Obviously, disruptions in how care is being provided. The elective concept for cancer is always a tough one, given the fact that elective, when somebody has cancer, elective is really not a choice that they want. They want to get that out or get that removed, but there are those situations that occur. So we're seeing from a surgical standpoint that there are certain types of surgeries that are being pushed, but more advanced types of therapies like pancreatic cancers, maybe some sarcomas, we're finding that they're going to be more in a situation where they need to have those treated sooner than later. So a lot of decisions are being made in these areas, but case by case is really kind of the norm at this point. Kate?
Yeah, thanks, Cory. And so similar to what you're seeing within neurosciences as well, we are encountering some of that sort of case by case interdisciplinary type decision making for more of that gray area of cases that aren't clearly emergent, but are more urgent, but can't be put off too long. So certainly some similarities there. What I do want to talk about, though, has to do with some of the emergent care that should be continuing that isn't. And I think here stroke is a really important one to touch on. So there's been a lot of effort to think through how we're going to maintain that continuity for emergent services. But what we're hearing are reports from many of our members of a sharp decline in stroke and TIA volumes and subsequently neurointerventional that are presenting to the emergency department to begin with, which is really probably indicative more of a failure to be calling EMS or seeking care, even in a real emergency. In fact, we've actually seen some payer data come out on this. Cigna just released a report where they had found that between February and March, the rate of hospitalizations fell by more than 30% for TIA cases among their 14 million commercial members, just to kind of give you a sense of the magnitude. But anecdotally, we're hearing numbers that are even more striking than that from some of the programs we've spoken to in terms of those stroke and neurointerventional volumes. So certainly very concerning, and we'll talk about some of the downstream impact of that. But on the flip side, among COVID-19 patients, we're seeing reports of more vascular events like stroke, among other neurological complications. And that doesn't even touch on the possibility of direct impact of the virus on the central nervous system. And that's being studied right now. So really the point is the ability to provide continuity and access to neurological expertise right now to recognize and treat some of this becomes all the more important as it ever was, right? And so sustaining adequate coverage has been a pain point for health systems since before the pandemic, but that's continuing to be an issue. But we're seeing a number of ways that systems are trying to kind of provide that, whether it's reconfiguration of teams internally, sometimes looking more globally across sites in a system to provide coverage. Extensions of virtual health is another. And in some parts of the world, we've actually seen neurospecific COVID-19 units to cohort some of those patients. So coverage is just one example, but I think an important one that neuro programs have had to continue on focusing on during this time. And with that, Rhae, tell us a little bit about what's going on in women's health.
Thanks, Kate. This is Rhae from the Women's Health Service Line team. And, I think the story, it's a little different than what my cancer and neuro colleagues are talking about here. There's a few things in women's health that hasn't stopped, but most importantly, it's childbearing, right? Babies certainly haven't stopped being born because of COVID-19. So inpatient obstetrics, those L&D units are still very much in demand. And actually, we have seen some headlines around this service line when we think about, we've heard about an uptick in out-of-hospital births at birthing centers or at home with midwives. But by orders of magnitude, births happen in hospitals in the United States. Actually, they're the highest volume service for most hospitals that do deliver babies. So this is not something that we're going to see shift outpatient. But of course, running these L&D units is not without challenges in light of COVID-19. So again, some of these are making the headlines. Women's health service lines have had to stand up policies around limiting support people and visitors in some markets, which certainly creates a lot of stress for moms and families. Giving birth during this time is certainly not how anyone might have planned for it or hoped for. So women's health service lines have had to kind of get ahead of these communications in a way that prioritizes consumer needs as well as their safety. Another challenge that has had to do with how do we handle mothers who have tested positive for COVID-19 or who are sort of under investigation of PUI. So now we're seeing women's health service lines who have worked quite hard to get those baby-friendly designations, actually having to separate mom and baby after birth, which certainly goes against everything obstetricians, want to do and have worked towards. So as far as breastfeeding goes, currently, CDC, ACOG, from what we know right now, we don't think that the virus can be spread through breast milk. So women who are suspected or have COVID-19 can still breastfeed, but certainly the experience is interrupted. From the physician side, We know, L&D coverage is another challenge. So we've seen physician groups that in normal circumstances are actually competitors are coming together and standing up new coverage models that minimize provider exposure. And then I think another point to make is really on the outpatient side. Certainly prenatal care hasn't stopped. And we see that some GYN treatments have also not stopped. Things like IUD placements are actually still going on. So it's really thinking about that obstetrics patient who certainly got pregnant at a time when COVID-19 isn't happening and still requires a high level of care.
Terrific answers from everyone. Thanks for quickly going through those highlights. So are those changes temporary, or is it accelerating a trend that you're already talking about? And Rhae and Karyl, I'm going to go back to you guys from the women's team to start, because I've heard you talking about some of those trends for the last couple of years.
Yeah, thanks, Trevor. And you're absolutely right. We anticipate, especially the shifts in prenatal care, to be part of an acceleration of those pre-existing trends. We've talked for a while about GYN wellness exams and some of the efforts to shift that to virtual spaces. We'll see things like contraception management over apps or even direct-to-consumer HPV testing. Now we are seeing a wider adoption of some of the prenatal care virtual technologies, so things like remote monitoring for blood pressure and weight gain, but also just having that prenatal care visit virtually with your physician. We hear, just like in primary care offices across the country, obstetrics offices set up prenatal care on the order of on a week basis rather than over years, as we may have liked to in the past. And we do expect that type of care, having some of those prenatal care visits remain virtual, will likely continue going forward. We also expect there to be some changes in how this could have some influence on how patients select their physician. So we had an interesting conversation with our clinical advisor, Dr. Miller, about how he could see some of those interview visits for new physicians, how do I choose my obstetrician for delivery? All of that could take place over virtual visits as well, especially with the video component. So thinking of those opportunities to continue to engage patients, we see that this may be a platform that patients enjoy more, and that this will be an enduring trend in the prenatal care space, certainly post-COVID.
And Kate and Gurmeet on the neuro team, do you think some of the trend we're seeing to telestroke are also going to get accelerated?
Yeah, this is Gurmeet. From the Neurosciences, we're seeing that virtual health is a continuation of a trend that we've already been seeing. The flagship use case that many organizations already have is telestroke, and we're seeing that use expand to other areas within neuro. In the hospital setting, one recent example is from University of Utah, who extended their pre-existing telestroke capability into their COVID-19 respiratory illness evaluation areas. At first, they were using this to assess patients presenting with stroke symptoms, and they later extended that to non-stroke presentations, whether it's multiple sclerosis exacerbations or seizures. We've also seen a rapid adoption in the outpatient setting with virtual visits and telerehabilitation. Now that providers have had some experience in this area, along with the relaxed regulatory barriers, we would expect people to continue leveraging these services in the future.
But cancer is a little bit of a different story, right?
Yeah, so this is Cory, and I think that as we're seeing, and Gurmeet kind of hit on it, and I think that as virtual care tends to be exposed more and more to the opportunities that it presents for caring for patients at their homes, we're seeing that same thing in cancer. And not that that's necessarily new, but the broader aspects of the capability of how to manage side effects of chemotherapy or reduce potential urges for patients coming into the ED. We anticipate that there are going to be long-term impact and opportunities to expand and broaden the use of virtual care in cancer. The other parts of this that we see potentially getting highlighted more and more is not that it is nothing new, but survivorship care has always been an important part of cancer delivery, specifically for those patients that need to continue to have that care team surrounding them. And I think the reality of it is that that's becoming more and more important. And the virtual aspects of what's happening now, I think, will only help embolden the opportunities with that, in addition to palliative care. So all these home-based type support care delivery opportunities, I think, in cancer are only going to be expanded and broadened and supported more and more. How much programs will continue to develop those opportunities, soon to be seen. But I think there's really an enormous opportunity to impact how patients are supported long term. Home visits and home care will also be opportunities here where we'll see infusions, even though chemotherapy and infusion in the homes are a little bit of a challenge. I think that there's going to be obviously a lot of discussions about how to kind of advance that as well.
Yeah, great example, Cory, and some similarities clearly across all three service lines. So let's go down the road a little bit. We're spending so much time working with our members, health system planning and operational teams, working hard, trying to plan for the very near term where there's so much uncertainty. So we're going to also think about longer term impacts. But first, let's think about just the next couple months. What could be some further changes in treatment or residual side effects from delayed care that we haven't seen yet? And Kate and Gurmeet, we'll go back to neuro to start answering this one, because you mentioned it and we've seen it in the national news, the decrease in stroke patients going into the ED. What near-term impact might that have?
Yeah, thanks, Trevor. And so certainly, I think that current dip in those stroke and TIA volumes is going to mean a few different things for us going forward, and there will certainly be some downstream consequences of that. Number one, for survivors, we'd expect to see increased morbidity, right? Some deficits that we'll need to be dealing with, and probably higher acuity of patients who are going to be seen coming in the next few months for rehabilitation, just as a result of failure to be able to intervene and reduce that initial damage on the front end that we'd be trying to do either through a thrombectomy or TPA or some sort of other preventative or therapeutic care. So kind of as an offshoot of that, as a result of that inability to start secondary prevention, we could also probably start to see increased stroke incidence downstream. And that could even really, especially for TIA patients, start in the next couple of months, especially for those TIAs whose symptoms seem to have resolved and they may not be seeking care because of that. They're going to be at elevated risk. And usually we'd be trying to intervene and really try to manage that as best we could and really kind of find out the underlying mechanism of what's going on there. And right now, it seems as though we're just not able to do that in a lot of cases. Sort of separately, though, across service lines, we have started to think about what reactivation looks like, especially for those elective surgical cases. And so that's certainly going to be true for neurosurgical care as well. So in that 1 to 2 month range, we'd expect to see programs dealing with, all the factors you'd expect, whether it's availability of testing, access to post-procedure or post-acute care even as barriers. And then in the longer term, probably some delays will start to appear just because we're not doing all the pre-surgical evaluations. For instance, a lot of those scheduled epilepsy monitoring unit stays are being put off for now. And so that could cause some backup. So in the near term, though, I think the other piece I just kind of want to mention quickly is that fear factor we're seeing that already is keeping patients away for some of those more emergent kind of conditions. I think in the next couple of months, as we start to try to think about reactivation, that fear factor could easily be a rate limiting kind of barrier as well. So just wanted to point that out. Cory, Kiran, what are you expecting?
Yeah, Kiran here. So as far as the postponement of screening, that should be a temporary adjustment. We should see patients coming back once, it's safer to be in the clinic and have a visit. But we do anticipate that there's going to be a little bit of a long-term effect there in terms of patients feeling safe, as you mentioned, Kate, patients feeling safe to schedule that screening visit and come in. In addition to that, the recession impacts could keep patients from coming in for their routine screening if they don't want to take the time off from work or if they're concerned about co-pays. Cory mentioned earlier the hastening the shift towards more home delivery of cancer services. And we've been watching things like Cologuard, the at-home prostate cancer screening through PSA urine tests. There's the possibility, the longer that this pandemic goes on, that we'll start to see patients opting for at-home screening options like this. And then, of course, this has also made the headlines lately from the oncology perspective, is the delayed screening is probably going to result in more advanced diagnoses over the next potentially months and years.
Kiran, this is Rhae, and I think we're seeing very similar concerns in the women's health service line, that delayed screening, thinking specifically about mammograms. We've seen those essentially stop in women's health programs. So, when we sort of dig out of this hole, we could see pent-up demand. Perhaps we'll see some women skipping a year. And then that will certainly have dramatic impacts on the sort of diagnostic care path. And also, again, that increased acuity of the breast cancer path that could be a result of those delayed screenings. Pap smears are another test. We're seeing women delay the gyne wellness visit. So there will be downstream impacts from that as well. Certainly PAPs aren't recommended as highly frequent as mammograms, and there is already sort of a lower adherence rate there. But we do suspect that access to the gyn-onc provider and even the gyn-onc's provider access to OR time and anesthesia support could be challenged within the next 1 to 2 months. I also wanted to comment, both Kate and Kiran mentioned the fear factor. And one thing that Karyl and I have talked a lot about over the last few weeks is thinking about how women's health will play a key role in the reactivation. A lot of consumers are fearful of accessing healthcare right now, and that will continue even once health systems bring procedures back. And so women's health programs have sort of, especially those that have really built a comprehensive offering, they tend to have built a trust within their communities and with women in their market who are often the key decision makers for their families. If you've talked to Karyl and I before, we've probably talked about that. And so we think that women's health programs will be really instrumental in bringing families back into the healthcare system because of that trust that they've built. So I think that'll be another key thing that Women's Health Service Lines will be working on in the next 1 to 2 months.
Yeah, good ones, Rhae. And I agree. And I'm going to come back to you guys here to think about longer term impacts. And that's because I heard a joke, and as a dad of 3, I can sympathize that any COVID bump in pregnancies, any COVID baby boom is only going to be couples who are having their first child. So obviously that's a joke that I think is funny, but is that the trend you're expecting? Or are you expecting something different? Let's talk about longer term impacts.
Sure thing. And I think that as funny as the joke is, there is a hint of truth in there as well. We have been seeing a decline in pregnancies just nationwide due to several factors, things like cultural trends towards smaller family sizes, average for age of first child is increasing. So we had seen a historical decline in birth rate really for several years now. And we are expecting that trend to continue and potentially even accelerate because of the COVID crisis. Some of the reasons for that are that we talked a little bit about how contraception access is still available for patients. IUDs are still being placed. You can still get oral contraceptives through a virtual visit. So access to contraception for those women who have insurance has not been impeded by the COVID crisis. We also see that economic downturns historically are correlated with declines in births. So if we look back to the Great Recession in 2008 to 2010, we did see a dip in births. There was a peak in 2007 and then a decline in the birth rate from 2008 to 2010. And it took us until 2014 to recover. And even then, the recovery was pretty anemic and began to decline again. So we have a history of economic downturns reducing the birth rate. We know that access to contraception is still in place for many women. And we think that those factors are going to be a bigger play than just those couples being trapped at home together. So we are expecting birth rate to continue to decline. We do expect this to influence acuity, however. Like Rhae mentioned earlier, there's a lot of fear associated with going to hospitals, going to clinic. That could lead to some patients avoiding care that they really need and potentially increasing the risk of their pregnancy. We are also anticipating as patients lose insurance, that does correlate with an increase in high-risk births as well. So we are seeing that while the overall birth rate will contract, there may be a rise in acuity. And there also may be some access challenges for certain women. Something I don't know if we've mentioned yet on the call, that the fertility services have been paused during the COVID crisis. So all of the women who are seeking IVF treatments or fertility support treatments, all of that has stopped during the crisis. And when they restart again, there will be some pent-up demand. But again, the economic strain that a lot of families are facing, as well as the high cost associated with those services, will also mean that the level of utilization of fertility services is likely to be down post-COVID as well. So all of that taken together, not expecting that COVID baby boom that's something that some people are talking about today. But Kate, Gurmeet, what are you seeing as long-term impacts?
Thanks, Karyl. Yeah, so I'll start off with the negative, and Kate will follow up with some positive side of things. And as we're thinking long-term about the residual effects, the idea of economic access barriers will be something that we'll be facing more frequently as people are out of work for longer periods of time. This is especially relevant in areas like multiple sclerosis, where we know that high out-of-pocket costs and financial toxicity are already a problem. we may see that patients may end up having a serious flare and may not get treated. Another area is spine, which is an entire topic of its own, and it'll have major implications as well. As people face economic challenges, patients may have to live longer with the pain as elective spine surgery may be delayed. Kate?
Yeah, that's a good point, Gurmeet. But I think also on the positive side, there are some certainly really kind of interesting things happening today that are probably going to have lasting beneficial impacts, as well as far as accelerating a shift in care delivery, just as some of the common models or competencies that we're really leaning on pretty heavily now are very similar to some of the leading practice models that some were working on prior to the pandemic, but hadn't always really had to fully commit to yet, right? So for one, acceleration of team-based care for decision-making. I know a few of us have mentioned that some organizations right now are gaining more experience with that interdisciplinary perioperative decision-making with regard to urgent cases. And that's very similar to what we've seen, say, in a spine center of excellence or maybe, a brain tumor program and that sort of thing, where we're also gaining experience with, things like telerehab, home-based EEG, some of these other services that we've had to adopt to maintain continuity in the meantime. That experience is probably going to benefit us in the long term, as now we've sort of gotten over the hump to adopt more of that. So certainly lots of examples we can point to where we're seeing that accelerated change. And I think that's the upside. Kiran, Cory?
That's great, Kate. Yeah, I'm glad you guys ended on the positive note here because we need that right now. But, from the oncology perspective, we already mentioned that the delayed screenings are probably going to result in more advanced stage cancer diagnoses, and that could result in a bump in surgical volumes over the next year or two. The longer that the COVID-19 crisis goes on, we're just going to have this continued need to protect immunocompromised patients, which, many cancer patients are. And so we'll just highlight that there's probably going to be a continued use of home infusion or, growing use of home infusion, continued use of telehealth for follow-up visits, a continued shift towards hypofractionation protocols for radiation oncology, which has already been a trend that we've been following regardless of the COVID crisis. As I mentioned before, we're seeing the adjusted infusion treatment schedules to help keep patients out of the clinic where possible. And operationally, we've talked to a couple different members where they've used staggered treatment times and adjusted their clinic waiting protocols. So interesting things like asking patients to wait in their cars where possible, and then, give a call to the clinic, or the clinic will give them a call on their cell phone to say, you can come on in now. And that helps kind of maintain the 6-foot social distancing and helps keep patients safe. So hearing all these service lines talk, there's so much interesting adaptation that's going on in these services to help providers continue to deliver care. And, I think we're really all in awe of the creativity and dedication that a lot of our members are showing, both from the strategy team side, from the healthcare provider side, of course, in terms of being able to continue to deliver care to patients safely. Really just amazed by the interesting ideas and creativity that are coming out of our members right now.
Yeah, and Karen, this is Cory, and I think what I'd like to just add to the point that Trevor brought up in the beginning, that I think that our service line specifically, I think it's not necessarily relevant to just one service line, but within cancer, there's such a multidisciplinary aspect to how care is delivered that it's really kind of testing a lot of programs about creating those opportunities to communicate with one another, to coordinate care, to determine kind of course of care moving forward. That really is important to service lines, and the programs that have really kind of stood those up are seeing some benefits to that creativity that you spoke to, and the ability to kind of deal with these case-by-case scenarios. So it is actually, it's really great to see a lot of our members that have really come together with these multidisciplinary approaches to care for these numerous types of patients in different situations. And so I think it's hats off to them. And again, a lot to learn and expand in that kind of work.
That was a lot of positive end. Good point, Kiran. And thanks for taking that tone, everyone. That's it for today. And for those listeners who may not know, most of this big team sits near each other in the office. So for me, this just made me miss you guys that much more. This was great. This was a lot of fun today. And to our listeners, also, there's another Vizient podcast, Modern Practice. It's on Vizient's Medical Leadership channel. I highly recommend it. It provides a clinical perspective into a lot of the current issues affecting healthcare today. Please subscribe or follow if you want to hear more. This has been another great episode of SG2 Perspectives. where industry experts and SG2 thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. Contact us anytime by sending an email to sg2perspectives@sg2.com. We'd love to hear from you. SG2 revolutionized healthcare demand forecasting with the Impact of Change forecast, and today, we're the industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks so much for listening, and we'll see you again soon.